Okay. Thanks,
Yeah.
Christine. I think for those of you who have to leave, we understand completely. I think we've got speakers who are willing to stay for a few more minutes, so we're going to run for about 15. But I know John Bernardo has to run to a meeting, and people are wanting to know what's life been like in Massachusetts. John, any comments before you run and words of wisdom?
I, I don't.
There you go. I can hear you.
You can? Okay.
Yes.
Uh, I just have to say that you need to be patient and work with the system. We've been living with the Affordable Care Act here since 2006, and the complexities that Tom highlighted are really apparent. Each insurance policy is different, and although 98% of our residents in Massachusetts are covered by the Affordable Care Act, the 2% that are not covered seem to make up a large part of who we see. Now in Massachusetts we have a benchmark plan that covers a lot of services, but it does not include TB services, including TB medicines, for example. It's an HMO Blue small group plan, so it's an HMO type plan, and for isoniazid they cover for $9 they'll give you 90 tablets of INH, even though we don't recommend taking 90 tablets away from the pharmacy at a time, but that's what they cover. And for a lot of our patients, $9 is a lot of money, and it's something we try to cover. Now we have 22 state-supported TB clinics around the state, and many of those choose not to bill third parties because it costs money, and there are high rates of claim rejections. For example, the largest clinic, state TB clinic in our state here, is at Boston Medical Center, and in 2012 there were over 7,000 patient visits to the clinic. Only 40%, or just under 3,000 visits, were billed to third parties because when patients come in, they were asked questions of whether they had insurance or not. And if they said yes, third parties were billed. And in 2011, 28% of those claims were rejected. So there's a default back to the state that covers the visits based on levels of service. For example, for an A1 visit, which is a physician visit with an X-ray, the state will reimburse the facility $86.28. Without the X-ray, it's $61.84. For patients with insurance who have copays, the state will cover $20 per visit copay, but it will not cover for deductibles. For DOT, the state will reimburse for example, for a 3HP pilot that we're doing, $20.74 for that kind of visit. So it's a patchwork that you have to work with. Medicaid does not cover TB drugs necessarily. It'll cover some, but not all of them. For example, it'll cover Levaquin, but it will not cover moxifloxacin. So if your physician wants to use Moxie, we have to go through a prior approval process. And for any of those of you out here who have gone through prior approvals, it takes time, and it's not a lot of fun, and you may get rejected. So it's complex, but we're working on it right now, and I'm optimistic we'll be able to work through it.
Well, thank you, John. So it really does sound like being patient and really finding out what specifics are in your area, and really kind of doing your own cost-benefit analysis for how you attack it and implement.
Well, a lot of our patients don't have insurance because they don't work, and they don't pay taxes, so they don't pay the penalty too. Or they'll buy insurance for a period of time to avoid a penalty and then drop it. So there are strategies that are used on the other side of the bench that will defeat the program. We do have what they call a health safety net that will fund services, including TB services, at federally qualified health centers and acute care hospitals for those who can't get Medicaid or Mass Health. So, but that doesn't cover most of our TB clinics because they're not located in health centers. So.
Good heads up, John. Well, I know in our last few minutes, we'll let you run off to your meeting, but I know, Tom, among our speakers, even Tom, you had a good question for Naomi. Do you want to go ahead and pose that?
Well, it's a little bit complicated, and I just heard this discussion of, people in a non-Medicaid expanding state. So if the state's not expanding Medicaid and say I make 75% of poverty, is it worth my projecting in 2014 that I'm going to make 103% of poverty so I can get the subsidies for insurance?
Can you hear me okay?
Yeah.
Yeah, so I've read about that as well. That's sort of bounced around because the subsidies, and the issue here again, just to reiterate, which was mentioned earlier, is that if your state's not expanding Medicaid and you're under 100% of the federal poverty level, in theory, you're allowed to buy insurance through the exchanges, but no provision was made in the law for subsidies for people who live below 100% of poverty because Congress assumed all those people would get Medicaid. And then unfortunately in my opinion, because of the Supreme Court decision, some of those people now will not get Medicaid and will not have access to the subsidies. So that is the problem, and an issue that's been bounced around in some advocacy communities, et cetera, is, well, could people, since it's based on what you project you'll make the next year, could we counsel people to project you'll make a little more so that you get over that 100% bump and can get a subsidy? I mean, this is all, it sounds ironic because it is. It's sort of like you have to show you're going to make more money in order to be eligible for a subsidy. And so it's this weird quirk of how things have shaken out. The problem is, I mean, frankly, what I and my colleagues have said to each other is you don't want to counsel people to commit fraud. You don't want to counsel people to overstate their honest expectation of what their income is going to be. I mean, this is an IRS issue. I'm not a tax lawyer, but I'm a lawyer, and you don't want to be counseling people to purposely exaggerate things to the federal government. Now, one thing that I do think is more legitimate is if, for example, someone works in a field where they get paid cash, like tips or other things, which maybe in the past they weren't reporting because they didn't want to pay taxes on them, it may now behoove them to report them because if they can show they're over a certain income, they'll be eligible for the subsidies. So I do think people should be encouraged to report all actual projected income for this new reason, but I worry about, counseling people to exaggerate.
That was great.
Interesting. Naomi, from your perspective, from having been on board in conceiving and writing this, any other advice you'd offer to the TB community in particular?
Well, one thing I'd say, and a big caveat to this, is that I worked on the House version, which is not the version that ultimately passed. So I do not claim myself to be an expert in the process of the version that actually became law. I think one thing that I think probably my guess is that listening to this call, a lot of people are still feeling completely overwhelmed and not sure where to start. And I do think, very basically, that so open enrollment starts October 1st, but a lot of information is going to start becoming available in September. And regardless of what state you're calling in from now, you can go in there to healthcare.gov and get linked up, whether you're in a federally facilitated state or state that's running its own exchange, get connected directly to much more concrete information. It'll say, these are the companies that are offering plans in your area, these are your options under Medicaid, et cetera. And I think, so again, in a few weeks, once we're into September, again, I'm not shilling for them, but www.healthcare.gov will allow people to get much more concrete about what's available for them and their clients in state, and I think a lot of this will start to feel a little bit more, more manageable. It's all relative.
Naomi, this is Julie Higashi. I have a question. It gets very, I agree with you, it's very overwhelming. Do you have a feeling about a huge difference in an experience one of the questions that came up in our national breakout on this at the end, National TB Controllers Association, were the folks from the states where there was not projected to be expansion in Medicaid. Is there going to be a major difference between that experience and other states that may not have their own health care exchange but will be having the federal health care exchange run? I mean, these are two separate questions, but is it your sense that this experience for everybody is dramatically different depending upon what the actual, I guess, structure is going to be for each state?
Yeah, I do think there will be a lot of differences state by state. And, again, it's going to be interesting to see if people think it's better to have a federally facilitated exchange or not. I mean, you could argue that, okay, so the states that are refusing to do it, the federal government's going to step in. On the one hand, no, it's not an agency that's been, intimately dealing with state-specific issues for a long time. On the other hand, they have kind of an economy of scale as far as, it's over half the states that are going to have federally facilitated exchanges, and so they're thinking a lot and have a lot of people dealing with, how we're going to manage this. So I think it's a little bit of a, I don't want to say a toss-up, but it'll be interesting to see, how different the experiences it is. Now, again, a lot of you are scientists. It's hard to control for the fact that the states that, that run their own exchanges are probably, they're self-selected to be states that are somewhat more engaged in trying to provide care, right, for their citizens. So it's, it's hard to sort out the different factors. But no, I mean, I really think, unfortunately, the biggest difference is going to be the Medicaid expansion and, what happens to folks who are below 100% of the federal poverty level, as Tom mentioned. And one thing I do want to know, I'm sorry, I didn't hear this come up earlier, but again, a little bit ironically, the one bright side or bright element to the no subsidies for people below 100% of the federal poverty level is that the law does allow subsidies to buy through the exchanges for legal immigrants below 100% of the federal poverty level. So for a lot of you, that might be a good chunk, even if it's still a minority, of your patient population. Legal immigrants under the law can get subsidies to purchase through the exchanges, and the reason for that in the law is that some states have a 5-year waiting period for Medicaid, even if you're here legally. So Congress said, okay, well, they're here legally, they didn't do anything wrong, let's make them eligible for subsidies, even if they're below 100%. So do keep that in mind, that the subsidies for purchasing, even if you're in a non-expansion state, legal immigrants under 100% of the federal poverty level can access subsidies.
Thank you.
Wandered a bit off topic there.
No, that's important.
I think it's all helpful information, and I think thank you all for bearing with us through the delays and this expanded time. I know that there are a lot of chat questions that are coming up, and I think what we'd like to do is hopefully we can still enlist our faculty to give written replies with us, because this is really a group with a wealth of information. I know we're all just wading these new waters together, but I think what we'll do is please go ahead and submit your questions. We'll collate them and see if the faculty as a group may have some advice or answers. Again, a lot of these things are left unknown, and we'll have to watch together. And like our colleagues in the HIV world, we'll be looking to continuing this discussion and helping all of our programs and colleagues work their way through this with the other RTMCCs and with CDC, moving the TB programs ahead. I think we'll end it. Thank you again very much for sticking with us. We really appreciated all the hard work the faculty have put into this. And thank you all for listening. We will post this on an archive. You do need to do evaluations, or we would love to have you do evaluations if you can. And thank you all. Take care.